In this session, we're going to talk about pulmonary vascular disorders. The pulmonary vascular disorders we will review here include pulmonary embolism, pulmonary edema, and primary pulmonary hypertension. So a pulmonary embolus is a clot that has traveled to the pulmonary artery. Most often it occurs when you have part of a DVT, deep vein thrombosis, in another part of the body that breaks off, travels to and lodges in the pulmonary artery. This obstructs blood flow, as you can see in the picture there, and it causes a VQ mismatch. Now, a VQ, I know this is weird, V stands for ventilation and Q stands for perfusion. Don't ask me why. But what happens is the mismatch occurs when the section of lung that is well ventilated is not well perfused, so no gas exchange can take place. And we've been talking about a lot of diseases that destroy lung tissue and you don't get ventilation to that area. And we've talked about lung tissue diseases that can destroy the lung tissue and the capillaries, so there's no ventilation or perfusion. This is a case where there is ventilation but no perfusion, so no gas exchange can take place and it effectively becomes dead space. No gas exchange is called dead space. Damage can occur to the lung from hypoxia, and you can actually get a lung infarction in the area of the embolus. As I mentioned, the etiology most often is from a DVT. Same risk factors are present as in a DVT. You can also get them during general anesthesia, heart failure. Sometimes in lower extremity fractures, you will get a fat embolus, and that can lodge in the pulmonary vasculature. Immobility, including long plane flights, you can get a DVT, and then that can break off. Obesity, oral contraceptives are notorious for causing DVTs in some people, and then also smoking predisposes you to DVTs and then also to a pulmonary embolus. So this illustrates normal lung versus a pulmonary embolism. So as you can see in the little blow up there, you've got a clot, and the clots are affecting several different places, and the area that air is getting through, the alveoli are inflated and gas exchange is taking place. The area that the clot is obstructing, there is no gas exchange taking place there. So the main focus of nursing care here is prevention. You want to prevent DVTs in a lot of different ways. Regular ambulation post-operatively, or really any time that it's not contraindicated, is always a good idea. Leg exercises while they're in bed is good. Sequential compression devices, SCDs, or compression stockings that like TED hose like you see here. These are all important if you've got somebody who's post-op or immobile for another reason. Sometimes they will give low-dose heparin or low molecular weight heparin, such as enoxaparin, as a preventative measure. If a DVT is diagnosed, prompt treatment is essential to prevent pulmonary embolus. And so if you've got somebody who's immobile, who's post-op, and says they have pain in their leg, pay attention to it and get them a provider to evaluate it as soon as you possibly can. Signs and symptoms of a pulmonary embolus are the sudden onset of dyspnea for no apparent reason. Just all of a sudden, the person starts gasping for breath and they are very, very anxious. They become tachycardic and tachypnic. They can have pleuritic chest pain. Remember, that's pain on inspiration, a really sharp pain. Sometimes you'll hear crackles. Sometimes you'll hear a friction rub, but not always. They can have hemoptysis, and interestingly enough, some people don't have any symptoms at all. Complications of a pulmonary embolus are pulmonary hypertension because you've got arterial occlusion. This can also lead to respiratory failure and then hypotension and shock, depending on how much of the pulmonary vasculature is occluded by the clot. You can die from this if death and treatment, or excuse me, if treatment is not fast and effective. So this is a medical emergency. Diagnostic studies, they can do a CT with contrast. It's a non-invasive study. They introduce contrast medium into your vein with an IV injection, and they do the CT. It's non-invasive, and sometimes that's all that's needed. A VQ scan, ventilation perfusion, as I mentioned earlier, radioactive dye is put in the IV, and it's also inhaled. And then you look for the areas of VQ mismatch. Look for places where there's perfusion and no ventilation. A pulmonary angiogram can be done. That's what you see here is a picture of an angiogram, and then the little arrows are the areas where the clots are. But this is invasive. So, it depends on the risk-benefit analysis as to what tests they use. Chest X-ray, EKG usually are only helpful if the pulmonary embolus is big. A D-dimer, ABGs also if you've got reason to believe that the person is hypoxemic or perhaps even getting acidotic from this. A D-dimer is an interesting test. You get a result in about an hour. So if you got somebody that you suspect a pulmonary embolus from, it's a blood test, and what it tests for is it looks for fibrin fragments that are left over from thrombus formation, and it can help rule out a pulmonary embolus. So if you have somebody who's got sudden dyspnea, no apparent cause, you draw a D-dimer, it can be available in an hour. If there are fibrin fragments, chances are there was maybe a clot somewhere else in the body that traveled to the pulmonary vasculature. If it's negative, there probably aren't any clots anywhere else in the body, and you need to look elsewhere. So it's a really useful, relatively non-invasive, and fast test to do. If you've got somebody who's in a skilled nursing facility, this is the go-to thing that you do when you're making the phone call to send them out. So therapy here includes thrombolytics in a life-threatening emergency to dissolve the clot. So you're looking at things like TPA here that they'll do, inject directly to the area in using pulmonary angiography. Heparin is used. It prevents new clot formation and also can prevent the extension of a current clot. The therapy must be used within 4 to 6 hours of clot occurrence if you're going to use thrombolytic therapy, and there's also a tremendous risk for hemorrhage, and so you really have to be careful with this. It's just exactly like what they do with a stroke or an MI, same thing. You can remove the clot, do an embolectomy with a cardiac cath, or you can do a surgical embolectomy. That's really rare. They will give supplemental oxygen even if the SpO2 is normal here, because oxygen can dilate the pulmonary vasculature and increase circulation around the area of the clot. Some people actually require intubation and mechanical ventilation. This is only for severe clots. And then you have anticoagulants. So I mentioned heparin. It's used first, usually given IV, and then that will be followed by Coumadin or one of the other newer platelet inhibitors for 3 to 6 months. And of course, you need to follow bleeding times for this. Sometimes they'll insert an IVC filter, inferior vena cava filter, if somebody has recurring PE. The problem is with these is that they've had issues with them, and they have caused a lot of complications by rupturing the vessel, and so they're very careful with the use of these now, and they're not used as much as they used to be. For nursing care, stay with the patient and keep them calm. This is very scary. It is a sudden onset of intense dyspnea, and it makes people very, very anxious. You want to raise the head of their bed, begin low flow oxygen, make sure you're doing a lot of good assessments, listening to their lungs, checking their oxygen saturation, their vital signs. Get a hold of the charge nurse and the provider immediately, and they will order an IV if you don't already have one, and then get ready for the tests and the IV medications that are certainly to follow. Prevention is the best intervention, and DVT prophylaxis is implemented for everyone who is immobile, who is post-op, anybody that you even suspect might be at risk for a DVT. Early identification and notification of the provider for any change in anybody who you think might have a DVT. It's very important to catch these things early before they progress to a pulmonary embolus. Um, any change in condition is important to report as well. Patient is kept on bed rest in the semi-Fowler position initially, but then you want to turn, cough, and deep breathe to prevent atelectasis, because of course then you've also got the complications of immobility here. The primary diagnoses, of course, are impaired gas exchange, anxiety, and risk for bleeding because they will be anticoagulated. Pulmonary edema often occurs with left-sided heart failure or after an acute MI. It is fluid congestion in the alveoli, usually caused from back pressure from the left ventricle. So you've got a problem with your left ventricle. It's not pumping as well as it should be because of heart failure or because of damage from an MI. And so you have increased residual volume of blood in your left ventricle, which backs up into the left atrium, which backs up into the pulmonary vasculature. And so the fluid moves into the interstitial spaces and alveoli because of that hydrostatic pressure, the back pressure caused from the left ventricle. Because you have fluid in the interstitial spaces and in the alveoli, the area for gas exchange is decreased. Signs and symptoms: severe dyspnea, orthopnea. Remember, orthopnea is when you need to sit up to breathe, and people get very anxious with this because they are so severely dyspneic. It's very scary. They have a cough and they'll produce a very thin, frothy, pink tinged sputum, sometimes blood-streaked sputum, and you'll hear fine crackles wherever the edema is present. If you look at this chest x-ray, the white area is where the edema is present in the lung fields. This pictures a normal lung and a lung with pulmonary edema. You have engorged capillaries from the back pressure, and the dependent airways are deflated because of the inability of the air to get into them. So you have diminished capacity for gas exchange. Your bronchial mucosa can also be swollen from the back pressure of fluid from the lungs. A diagnosis is made with a chest x-ray. You saw that in the previous slide. They will sometimes use arterial blood gases, and if you do a cardiac cath, you'll see elevated pulmonary artery pressures. You can also see elevated PA pressures on an echocardiogram. This picture up here shows you the blue is fluid that's built up in the alveoli there. Therapy, you basically want to concentrate on reducing the workload of the heart to improve your left ventricular function, reduce the pressure in the left ventricle, and therefore reduce the pressure on the pulmonary vasculature. So cardiac meds such as inotropic medications, DIG cardiac glycosides, diuretics to decrease the fluid overload. Morphine can actually be helpful. It can dilate the pulmonary vasculature and help with the dyspnea. Positioning is important. Of course, you want to sit them up in semi-Fowlers. You want to give them oxygen and just really work with them on reducing their anxiety, deep breathing, and calming down. Acute pulmonary edema is a very scary thing. Pulmonary artery hypertension, also abbreviated PAH, is elevated pressure in the pulmonary artery. It's caused by a variety of mechanisms. The current labeling of pulmonary artery hypertension is done in groupings based on the pathophysiology, clinical symptoms, and the different treatment options. You don't necessarily need to know that. The classic symptoms are dyspnea and fatigue. Other symptoms are chest pain with exertion, dizziness, and syncope. Eventually, pulmonary hypertension causes right-sided heart enlargement, which is cor pulmonale, followed by heart failure. Again, it's back pressure, just exactly like what happens in the left side of the heart with pulmonary edema. This happens in the right side of heart. You've got elevated pulmonary artery pressures. The pulmonary vasculature is a low pressure system normally. When you get high pressure there, that pressure backs up into the left ventricle, into the left atrium, and causes right-sided heart failure. There is no cure for pulmonary artery hypertension, but treatment can improve or relieve symptoms. It can increase the quality and the length of life, and also treatment of the underlying cause, whatever that is, can help improve symptoms. Drug therapy can lower the PA pressures by vasodilating the pulmonary vasculature. Calcium channel blockers can be used. There's a prostacyclin called epoprostenol. I think Flolan is the name of it. Can promote pulmonary vasodilatation. Calcium channel blockers are oral. The prostacyclin is administered IV through a central line. Other medications that are used quite frequently are oral phosphodiesterase inhibitors. So you think of Viagra as being a PDE type 5 inhibitor that is used for erectile dysfunction. They use that same drug under a different trade name for pulmonary artery hypertension. They also use anticoagulants, diuretics, DIG, supplemental oxygen, whatever they need to do in terms of the symptoms of right-sided heart failure. Lung transplantation is reserved for people with pulmonary hypertension who don't respond to treatment, who progress to severe right-sided heart failure, and quite often what they'll do is a combination heart-lung transplant.